and that can cause harm before you know about the diagnosis. So, for example, the classical one was congenital hypothyroidism, meaning that you were born with no thyroid gland, and by the time the doctors were able to make the diagnosis at 3 to 6 months of age, the baby's already suffered irreversible brain damage, and if you could make the diagnosis, you could treat them and they would never have any brain damage. And so that's what started newborn screening. They realized if we could make this diagnosis on a blood test before the patient had symptoms, and we have a treatment that's cheap and easy and works, then we should do it. And so newborn screening started off with 1 to 2 diseases. In some countries, they measure the thyroid. They look for congenital adrenal hyperplasia. They look for fatty galactosemia, maple syrup urine disease. There are a bunch of diseases that if you can diagnose them before the kid gets sick, you can save their lives. Most recently in the United States, we now screen for about 30 diseases. So the question arises, should we not screen for hyperinsulinism? And so the question is, how could you screen for hyperinsulinism? Well, number one way would be to do a genetic test. But as those of you who've had the genetic tests done know that it costs about $5,000 in the United States to have the testing done, so that's not going to work. And I'm sure President Obama would love to mandate that we all have an extra $5,000 spent on us, but that probably won't work. So the question comes up is, what about if you just measured the glucose? Well, that sounds like a real simple thing to do. So how would you measure the glucose? Well, newborn screening is done by a Hill prick card. You put blood on the card, it gets shipped off to the lab, and it's measured in the lab 2 to 3 days later. Well, while that blood is sitting in the cardboard, those red blood cells are alive, eating up glucose, so every newborn screening card is going to have a low blood sugar, so that doesn't help. So what about just doing a blood sugar test on everyone? Well, you would think that that would help, but currently in the United States, probably 30% of babies have a blood sugar test done on them anyhow, and most of the times the neonatologists will just assume that the baby's having a low blood sugar because that's what happens to babies. 30% of all babies who are born in the first 6 to 12 hours of life will have a low blood sugar. It's a normal thing. The blood sugar comes up and they stabilize. And so our neonatologists in this country and in most other countries will say, well, they're just one of the normal 30% who had a low blood sugar, and they ignore them. So the problem is not doing the testing. The problem is raising awareness in the neonatologists that 1 in 50,000 babies has hyperinsulinism, and it is your job to separate them from the other 49,999 babies who don't. And that's the problem. It's not whether you do the test or not. It's what you do with the information.
Okay. As a result of HI, can you develop underactive thyroid?
So the question is can you develop hypothyroidism or an underactive thyroid because you have hyperinsulinism? And the answer is no. However, there are a couple of caveats. Number one is, if you have bad hypoglycemia and you can cause brain damage, then you can damage your pituitary gland.
Sorry.
And your pituitary gland is what controls the thyroid. So indirectly you could. And secondly is that some of the medicines we use, namely octreotide, can impair thyroid hormone secretion. So octreotide can cause hypothyroidism. So that has to be watched for as well. So not directly, but indirectly it can occur, yes.
Okay, another one is, I have trouble finding medicine at the pharmacy because they don't keep it in stock. Why is that such a problem? And how can, and this is something that we've discussed as an organization, how can we call Walgreens or a company and inform them, okay, if a family's going to a certain pharmacy, can't they keep it in stock without them saying, oh, wait a week? They're having trouble going to even the same pharmacy they've been going to get, is it
diazoxide? Okay. So the question is that why is it difficult to get diazoxide, and why can't the pharmacies keep it in stock? Well, the first reason is that when your baby is newly diagnosed with hyperinsulinism and you go home to your hometown, you are probably going to be the only baby in that town with hyperinsulinism. So the pharmacy will not have the medicine in stock, and so they have to special order it. And some pharmacies are very good. It's like all businesses. Some are very customer friendly. They realize that you're going to be a customer for life. They realize that you're going to need your diazoxide every 28 days. And at the end of the month, they'll order in another bottle and have it ready for you. And some pharmacies are not good with their customers and don't care less, and they don't want to have a bottle of diazoxide on their shelf in case you decide to go to Walgreens instead of Walmart. And so they don't have it stocked, and they wait for you to come in, and then of course it's not available and they have to have it shipped in from the wholesale distributor. So that's really the reason. It's all about customer service in a pharmacy. Now, there's another problem, and that is that intermittently the supply of diazoxide gets disrupted. So recently in the US, I think it was about a year and a half ago, we had a disruption in the supply of diazoxide because there was a problem in the manufacturing plant, and because only one company makes the drug. When that goes offline, there is no drug available. And so that's the problem. And so the last time that happened, both some of the major centers, certainly in Fort Worth, we contacted the manufacturer, and there were discussions had, I believe, between the manufacturer, perhaps Dr. Stanley in Philadelphia, and the FDA, and they said that this is a life-saving drug and we need to have some released on compassionate use. And so we had a box of 20 bottles that we could give to our families who ran out. So if you're having problems with supply, go back and talk to your endocrinologist. The other problem is that diazoxide is not available in every country in the world, and that's a real problem. So a lot of times I'll get an email from someone in another part of the world saying, could I write them a prescription and ship them the drug, which I could do. It'd be very easy. I just get my pen out and I write the prescription, but it's illegal and I could lose my license. And so I also have to feed my children like you guys have to feed yours, and can't do it. So it's not that I'm being mean. It's that it is illegal for us to write a prescription for someone we haven't seen and to ship medicine across international borders.
Is that illegal in general, like for families? Can, let's say, can Amber ship something to another family if they need it? Is that illegal?
No. What a private person does is a different issue.
Okay.
But I can't practice medicine outside of my jurisdiction or across state borders.
Okay.
And so prescribing a drug for someone that is you haven't seen is considered practicing medicine across borders, and I don't have a license to do so. So that's the problem.
How many?
So for example, what I've seen happen there is that a family will come over, they will see a physician in this country, they will get their prescriptions, they'll have a family friend living here. The drug will be shipped to the family friend, and then they'll either carry it or ship it over.
Okay.
Oftentimes you can carry it. You can get enough, 3 months, 6 months, and carry it across.
How many families have one child with HI, one without? We were told at genetic testing that it can hit one child and miss the other.
So the question is how many families have one child affected and one without? Well, the answer is that's typically what you will see. If a genetic disease is running in your family, and let's just talk about diffuse disease. If you have diffuse disease due to KHB channel defects, it means that both the mother and the father carry the gene, and therefore there is a 1 in 4 chance that any child will be affected. So you could have 4 children, and if you were lucky, none of them would be affected, and if you were horribly unlucky, 4 of them would be affected. Each individual child has a 1 in 4 chance, and just because you have one affected doesn't change the chances on the second child. Each individual child is an individual risk of 1 in 4. So if you've got 4 children, statistically you will have 1 child. However, you all know if you toss a coin, you don't always get 50 heads and 50 tails, and that's why we have casinos, because people are willing to gamble. Now, if you have an autosomal dominant form of hyperinsulinism, there's a 1 in 2 chance that you will be affected. However, if you have one of the forms of hyperinsulinism, such as glutamate dehydrogenase or glucokinase hyperinsulinism, and neither parent has it, and the baby got it because of a spontaneous mutation, meaning that something happened in the development of the baby that gave them the mutation, then the likelihood of having another child is less than 1 in 100. Now, if you have focal disease, it means that one parent, the father, carries the gene and the mother doesn't. And we believe the risk of having a second child with focal disease is less than 1 in 100. So the number we quote is 1 in 100. So 1% risk.
How often are safety fastings done, and if the child does well without the feeder hooked up, how many times would that have to happen before they go without the all-night feeder?
So the question is how often do you have to do a safety fast in a baby with hyperinsulinism?
And then he adds, then have it removed if necessary.
Yeah, and then if you're on overnight tube feeds, when can you take the tube out and stop the feeds? So that's a very interesting question. And the answer is it depends on individual patients. So for example, if you are very, very well controlled on, say, diazoxide, and you're able to fast 12 to 15 hours, and you don't drop your blood sugar, then you probably need a safety fast every 1 to 2 years.
Okay.
And really the reason to do it is to see, can you keep lowering the dose of drug as you get older. On the other hand, if you've had a 98% pancreatectomy and your blood sugars are going low 1.5 to 2 hours after you feed, you probably need a safety fast every twice a year. Until you get to the point where you're able to feed on a normal pattern, so that would be 4 hourly during the day and 8 to 10 hours overnight without going low. And once you can do that, and the child is old enough to eat on command, you could probably take the G button out.
Okay, I'm sorry.
So the answer is it's an individual thing, and you need to talk to your own endocrinologist about it. And there are some endocrinologists who don't feel comfortable doing safety fasts. So for example, a lot of patients who come to see me will come and see me and have their safety fast done with me, get a tune-up done once a year, and see their endocrinologist the rest of the time in their local state. Because sometimes it's very hard to get to a major center.
Can I ask a question, Adam?
Yep.
If a child who hasn't had surgery, is there really any purpose in doing a fast?
So the question is, if the child has never had surgery, do you need to do a safety fast? The answer is yes. The safety fast has nothing to do with the surgery. It has to do with how well controlled you are. Now, for example, if you're at home on tube feeds, having low blood sugars on tube feeds, you don't need to do a safety fast. You need to increase the tube feeds. So it's really a matter of the better controlled you are, the less frequently you need to do either a safety fast, and the less well controlled you are, the more frequently you need to be making adjustments in the program. And we like to do them on our best controlled patients every couple of years, because what happens is that the families, if they're not seeing any lows at home, they slowly but steadily decrease the frequency at which they're doing the blood sugars. And as kids get older, they decrease the frequency. So it's nice to bring the child in, fast them for up to 24 hours just to show that they're doing okay. And it sort of reaffirms that the family doesn't need to be doing blood sugars, all the time. So actually, 24-hour admission can save you a lot of time during the year, so it's worth it. But I have to say, I don't know anyone who enjoys coming in for a safety fast, which is why you're all trying to get out of it.
Why is it so hard for HI families to get insurance? Kenesha.
So the
how we've
question,
been discussing in our group about how do they automatically qualify for Medicaid? We have several moms that I don't even know how to explain it.
okay, well,
You
I
do better.
So,
The question.
so the question is that why is it difficult if you have a baby with hyperinsulinism to get insurance? So let's talk about the two different types of insurance. There's commercial insurance in the United States, and there is Medicaid or state-sponsored insurance. In the UK, you guys don't have to worry about it because you've got a national health care system.
Yeah, they do.
So the first point is that insurance companies are companies that are owned by stockholders, and the only function of the insurance company is to make profit for the stockholder. Now, you and I might think that their function is to provide quality health care to their patients, but that is not correct. Their function is to make a profit for their stockholders. So if you have a disease that they know is going to cost millions of dollars over a lifetime to treat, and you come to them and say, I'd like to be insured, they're going to say, no thank you, because I'm not going to be able to make a profit out of you. If on the other hand, you have insurance already, and as you know, when you have insurance, you have 30 days in which to notify the insurance company that you've had a new child. If you notify them in that 30 days, they cannot kick you out because you have hyperinsulinism. However, if you let it go 10 seconds over 30 days, you're a goner. Which is why President Obama introduced healthcare reform to say that no pre-existing conditions could be excluded. Now that sounds wonderful for everyone in this room, no pre-existing conditions excluded. So what happens? Well, what we do is none of us bother paying $10,000 a year in healthcare premiums. We wait till we get sick, and then we go to the insurance company and say, you have to hire me. Well, that's like not getting home fire insurance on your house. So you wait till your house burns down, and then you say, okay, I'd like to get fire insurance, and they say, certainly, that'll be $3,000 a year, and you say, okay, now my house just burned down, I need $300,000 back from you, and as soon as you give me the check, I'm not going to continue my insurance because I only have to get it after my house burns down. So it's the same as any insurance. You have to get the insurance before they know you're sick. Or if you already have insurance, you cannot